Okay, so then we talk about the 3-tier system. Very, very pleased about this. So this relates to our red flags, and it determines our settings for where we manage our patients. So we start with the top tier, and the top tier is urgent hospital admission. So over here, I've used AI to generate this little image over here, and the top criteria is urgent hospital admission. So ask those red flags for which you need to get this patient into hospital immediately. Because if they fulfill that criteria, nothing else matters. You don't need to make any other clinical decisions except to get them there. So ask those questions early days, get those information, make that decision in your head. Fine, I'm getting this patient to hospital, all right? So if they need to go to hospital, send them in. That's the top tier done. Great. Next, if they don't have any red flags relating to top tier, they don't need to be admitted to hospital, then we're going to the middle tier. I'll start asking questions about urgent referrals, right? For example, is this somebody who needs access to rapid access chest pain clinic, need to be seen within a week? Is this a 2-week wait malignancy clinic? Is this a concern around rheumatoid arthritis, for example, and rheumatologists recommend they be seen between 3 days to 2 weeks because of the concerns around erosions around the joints? So urgent referrals next. If they're fulfilling those criteria, that's what you need to do, and that's the level in which we're taking care of them. Okay, so if they're fulfilling malignancy 2-week wait, do that criteria and deal with it then, and arrange for appropriate follow-up at an appropriate juncture. And lastly, if they don't fulfill either of those criteria for admission or an urgent referral, everything else can be managed in the community. This is where we give out trials of treatment. We use time as a diagnostic tool. We use advice and reassurance. We give them the tools in which we say, we're going to try something, but when things change, come back and let us know. This is the point at which we're going to review things and see if they're improving or not. Great. So I've included the slide very quickly, but everyone should know the traffic light system for serious illness for pediatric patients. We covered this obviously in our webinar last, but it's really important to ask these questions early days. I see a lot of consultations with children, and there's a lot of history taking with the patients, with the parents, and getting their perspective. But hard evidence is asked late on. It's very simple to ask these red flag questions. Has your child been weeing in the last 12 hours? If the answer is no, that patient needs to go into hospital, right? So these questions you need to get out there early days. I find that the consultations that are least structured are the ones in which we're just following the patient's narrative. What has happened? What happened next? Etc. etc. We're not asking hard questions to get objective facts. How seriously unwell is this patient right now? How have things progressed? Have they actually responded to any of the interventions we've put forward so far? So these are the questions we really need to ask, and we need to ask early days. Great, so let's talk about the Royal College curriculum now. So I thought this was a useful one to incorporate so that we just gain an understanding about how they think about testing us in this domain, right? So of course, lots of signs and symptoms, acute illness, adults, children, but they want to point out that acute exacerbations of chronic disease is something which they can test. We see a lot of that in primary care, so it's really important to recognize what comorbid conditions can really take a turn for the worse. Important signs and symptoms that may indicate severe illness, of course, and sepsis. Recognizing sepsis, asking those questions, really, really important. They've made this incredibly wordy sentence, but I felt like this is quite relevant to talk about. So, important signs and symptoms that may indicate severe illness, but which may be produced by other less severe illnesses, and strategies to avoid missing those severe illnesses when not obvious at initial presentation. For example, viral symptoms in the child should not exclude recognition of sepsis.